Thank you for giving me this opportunity to present here. I think this is one of the toughest title given to me. The application of liquid biopsy in real world. So, before I get into this, I just want to make sure that why it's important. See, there are a lot of panels we design, we have in the market, but it's important actually what you have on the panel and how you can detect that, how it has been designed. That makes it different. So I think I'll skip this. See, what we know today about tissue biopsy, there are a lot of issues with tissue, and sometimes it's not available, sometimes it's difficult to do the biopsy, and because of that, we are not able to understand the molecular profiling. And more importantly, now we are talking about the longitudinal monitoring of the disease. And this was one of the study where they have done ctDNA and tissue DNA, and it shows high concordance there. And if we see the biomarkers in the lung itself, and it has been well validated now in the, I think this is what is very important aspects. Tumor heterogeneity, we know it very well, and if we talk about primary tumor heterogeneity, there is the difference between the colonal populations, and then when we go to the different metastases, be it a brain, bone, or liver, and you see the intrametastatic heterogeneity, and I think that's where this tumor heterogeneity is actually impacting the success of the tissue biopsy, and hopefully the ctDNA based liquid biopsy can help us to identify that tumor heterogeneity, and more importantly now we see to identify those resistance signatures out of this. And second issue is tumor is evolving. This is the biggest issue. So what we believe that if you have to successfully treat the cancer, you have to treat at the speed of the cancer. And this is one of the study where they have done the comparison between tissue and liquid within 2 weeks, within 2 months, and within 6 or more than 6 months. What you see there is, if tissue is more than 6 months old, you miss 40% of the information, and possibly the 40% of the information is the ones which has evolved, which has occurred, and which might lead to the resistance to the treatment. And a few years ago, there was a statement from the ASCO, even for the patients who are able to undergo a traditional tissue biopsy, a liquid biopsy may be safer, quicker, more convenient, and perhaps more informative. That becomes a very important now here, So when we talk about the liquid biopsy, we often say, sometimes ctDNA, sometimes cell-free DNA. These two terminologies are interchangeably used. But what is the difference between the two? Cell-free DNA is the DNA fragments coming into the circulation from the normal cells, mostly hematopoietic cells, and they are about 200 base pair long, in size. And on the other hand, ctDNA is the small DNA fragments, about 150 base pair long, coming into circulation from the cancer cells, and the half-life is less than 2 hours. So what you see, the pictorial representation, blue dots represent the cell-free DNA coming from the normal cells. So on the other hand, a green dot represents the ctDNA coming from the tumor cells. It literally becomes needle in the haystack. Thanks to the technology, now we have the ability of picking up few molecules of ctDNA from the background of the cell-free DNA and able to do the molecular profiling on that. So when it comes to now liquid biopsy, I just want to look into the last year, ASCO. If we look at the number of abstracts published in the ASCO in last year in various indications, various biomarkers, were about 370 abstracts. A decade ago, there were only 10 abstracts in this. That shows the amount of research going into the liquid biopsy and showing the promise of this liquid biopsy. So out of this, this 370 abstracts, 9 were from us, one cell last year, and then 10 were this year in the ASCO, and we had 2 abstracts in ESMO. We had 4 presentations in International Society of Liquid Biopsy on various biomarkers and various indications, But that sounds great. What does it mean to the oncologist who's practicing in their daily life? So some of the studies, one of them was, how can we use the liquid biopsy to monitor the, disease progression or monitor the therapy response? So this is one of the examples how we are able to identify the, progression much before it could be captured by PET scanning. And second was, can we identify the resistance signatures and how they correlate with the imaging technique? So some of the study which we have been doing with Dr. Kumar sir, one of the clinical endpoint was, how can we differentiate? What does it mean to the patients? So if you look at these two results, both progression-free survival and overall survival, patients were stratified at the baseline based on the resistance signatures which were captured by liquid biopsy, and we could see there's a significant difference in the disease outcome. And what does it mean? If you look at the ctDNA dynamics in responders and non-responders, if you see at this results here, at initiation, during treatment, and the last time point, and you could see the clear trend. ctDNA dynamics is clearly telling us that how these responders are actually responding to the treatment. On the other hand, non-responders, how the ctDNA dynamics or ctDNA load is increasing there. Now again, this study was done with Kumar sir, who is here, and in fact he has presented last year in in presentations. We are also doing a study on concordance on tissue and liquid using our this proprietary panel of 1080 genes. So we call it alpha lung study, and target is about 500 patients, and hopefully in another 2 months we'll have complete results. But initial results, what it shows, when I looked into lung specific biomarkers like what are in the NCCN guidelines, on the left hand side you see that how we got them and how concordant was there. On the right hand side, what you see is it's not a sensitivity, it's a detection. And what is detection? I mean is when you look at those markers, if you go in tissue, we have about 84% of detection of those markers. When you go into the liquid, it's in 86% of the. But when you combine that, that increases. In earlier presentation we have seen it. Somebody showed that there is a 5% difference between liquid and tissue, but it's in the both sides. When you combine them, it becomes 10%, and that 10% shoots up. That's what is important. It may not be make big difference, but even one patient you identify, and that is important because we are talking about precision oncology, and even single patient matters. Even if it could be less than 1%. And there is a guidelines clearly showing that when to do tissue biopsy, when to do liquid biopsy, and it has been discussed earlier. I want to skip this. In NCCN guidelines we have now liquid biopsy is part of that. Now what is important? Now we know that data has shown that there is a sensitivity and specificity. There is a concordance between tissue and liquid. Of course, there is also false negative results, what you can see in the liquid biopsy, but that's what we know today. If liquid biopsy is negative, that doesn't mean the patient is negative for that. We have not detected there. Therefore, we may have to do is a tissue biopsy. And of course, we are seeing improved TAT and other important factors. So we have seen also, how this tissue and plasma, you can see the significant difference in terms of overall survival. So I'm skipping these because I have only 2 minutes left. And there was one study where they have done this, quality of life. What you see, it's when you do the liquid biopsy, you have improved quality of life parameters as well. And these are multiple studies where they have done the meta-analysis to understand the actionable alterations found in tissue and liquid biopsy, how it is improving there as well. And this, I found this very interesting. Does molecular result timing matters? And in fact, this is what is here. If patients who have been treated after report comes, that's the A group, and in the B group, in the patients treated before report comes, and then switch to TKIs, and the C group is when patient has been already treated with the chemotherapy and then not switched to the TKIs, and you can see that there's an overall survival benefit if you get liquid biopsy earlier and treat according to that. So I think we were just discussing about that, how it becomes important liquid biopsy. This was EGFR alpha negative patients, and we have captured PTEN mutation, which leads to actually resistance to the immunotherapy because it induced that environment like IDO1, PD-L1 expression, tumor regulatory cells, and therefore it becomes very important. And it's not only that, as earlier speakers spoke about that, combination of tumor mutation burden with PD-L1. Similarly, I say combination of genome instability, including tumor mutation burden, genome-wide HRD, loss of heterozygosity, and PD-L1 can improve the prognostic impact of these biomarkers. And of course, when we talk about the genomics, it becomes important, variant of unknown clinical significance, and the interpretation becomes the key. Like in this case, this was a dual EGFR positive patient who has progressed on afatinib and shown resistance to TKIs. What was the reason? And what we found is MET and PIK3 mutation, which were variant of unknown clinical significance. When you look the close proximity of those two mutations, MET particularly was very close to exon 14 mutation, has a similar biological molecular impact, therefore it is the reason for that leading to the resistance to TKIs, and combinational approach is better there. And another case was, it was an actually history of a breast cancer and second primary of adenocarcinoma of lung, and when we got the report and we found EGFR mutation, and the doctor is a question, is EGFR negative, because they have already done this test. When we asked the report and we looked into there, because it was a hotspot testing, and that's why it becomes important. When we do the hotspot testing, we need to know, if that particular mutation is covered or not. And I also want to highlight just another 30 seconds, liquid biopsy beyond blood. We know there are other body fluids, including saliva, CSF, urine, etc., and they play an important role, and how that increase the, sensitivity of the liquid biopsy. Just one case here, it is increasing sensitivity. It was a, non-small cell lung cancer who was known for EGFR positive, and in the blood we found, I think it was negative, but when you see in the CSF, we found exon 19 deletion with VAF of 92%, HER2 amplification 21 copies, TP53 VAF of 87%. So this is where it becomes important. When we discuss this with the doctor, his question was why blood is negative, why CSF is positive, and we did our homework and we went ahead, and what was the reason for this is when you have this parallel canal space of the brain involved, shedding do happen into the blood. When meningeal space of the brain is involved, the shedding happens into the CSF, and then we came to know that this patient has a leptomeningeal disease, and that's the reason. And the second question was whether we should be treated with osimertinib or trastuzumab. At the end, we know that these are two pathways active, and therefore both has to be targeted. And this patient was put on osimertinib with intrathecal trastuzumab, and this test was done in the May. Until today, patient is doing very well, and this is why it is important. And we know there are multiple challenges, and we most of the time talk about cost is one of the challenges. This was one of the study. Of course, is about 27%, but if you combine others, which is awareness, access, sample quality, time, that is actually more than 50%. That is the time. This becomes important. Liquid biopsy reduces the time. It also gives us opportunity to analyze the tissue which is not possible, and sample which is not possible on tissue, but we can do on the liquid biopsy. So with this, I understand that we often give the bias to the tissue, considering that's a gold standard. What I see today is that tissue which is considered gold standard has become old, and the liquid is the new solid, and bias should be given towards the choice of doing this comprehensive testing based on the understanding of tumor biology, tumor evolution, tumor heterogeneity. With this, thank you so much.